is going to be adequate for that particular patient. So it needs a careful prediction and how we are going to predict the fluid responsiveness. That is what is going to be my discussion for the next 20 minutes. Okay. Can we predict the fluid responsiveness based on the history or in the clinical signs? Yes, if the signs are very obvious. For an example, a patient, acute trauma patient comes to you in the emergency room, you are seeing the patient, or who's bleeding for some other reason. Signs are very obvious. There is no point in going for these type of tests and signs. You straight away give them the fluids. But it doesn't work. As my earlier slide showed, only 50% of the patients without the active or acute clinical signs are going to be benefited by fluid infusion. So how are we going to see them or pick them up first? Before that, you should know why this difference in response. Some of them are responding to the fluids, some of them are not responding to the fluids. Why? Anybody? So basically, the Frank-Starling curve determines the approach, this approach. What is this Frank-Starling curve? It tells you the relationship between the preload on the x-axis and the resultant stroke volume on the y-axis. Okay. So this has been, since morning it has been few, my previous speakers have spoken about this. So what does this Frank-Starling curve tell you is, as the preload increases, the stroke volume is going to increase. That's the first step. It is something like a catapult, as you all know. As you keep increasing the catapult length, the force what is going to be generated is going to be much more. But this linear shift is not going to last forever. Initial period, yes, when the curve is in the steep position, the linear shift is maintained. But once it reaches the plate of phase, the linear shift is lost. That's what this curve is. So that means if the patient's ventricle is going to be operated in this area, if you are going to give fluids, the patient will respond by increasing the stroke volume. But for an example, if the patient's ventricles are operating in this plate of phase, whatever fluid you are going to give is not going to have a resultant effect, but unfortunately it will push the patient into the other side, signs of fluid overload and poor outcome. So you have one area of the preload dependent zone on one side and one area of preload independent zone on the plate side. Is it so simple? No, because there is no single curve. For a same patient, the curve may vary between time to time, or there may be family of curves between the patients. So if the patient, a young adult who do not have any comorbid conditions, this curve is going to be like this. So whatever fluids you are going to give is going to have a good effect. But whereas the other hand, if you are going to have a patient with a cardiac abnormalities, with an LV dysfunction, whatever it is, the patient's steepness, the curve steepness is only very limited. The same amount of volume which is going to work for this patient will not work for this patient, and this will push the patient into the signs of fluid overload. So we need to understand that where exactly this particular patient's ventricles are operating. Okay. So how we are going to predict the volume responsiveness? Traditionally, they are divided into three categories: static parameters, dynamic parameters, and volume challenge. So since morning we have been talking about the CVP, occlusion pressures, IVC diameter,